ECDC On Air,
the podcast of the European Centre for Disease Prevention and Control.
Keeping up to date with European epidemiology.
Hello and welcome to this podcast of the European Centre for Disease Prevention and Control. My name is Catherine and today I'm your host, recording from our headquarters in Stockholm, Sweden. In this episode, we are going to talk about one of the activities performed by ECDC, which is the surveillance of infectious disease. What does this activity of surveillance cover? What kind of data are we talking about? Where do they come from? With us today, we have Julien Beauté, who works at ECDC as an expert in general surveillance. Hello, Julien.
Good morning, Catherine. Thank you for having me here.
It's a pleasure to have you here, and I would like to ask you, how long have you been working at ECDC, and what brought you here?
Right, so my name is Julien Beauté. I'm a medical epidemiologist, been working at ECDC for about 10 years now. Before ECDC, I was trained as a medical doctor, specialized in public health and infectious diseases. I've worked for a university hospital in Paris for a few years. Then I worked for the Institut Pasteur in Cambodia, back to Paris for the headquarters of the university hospitals, doing some health technology assessment. And then I moved to ECDC to join the surveillance team. I've worked under different positions here, but always related to surveillance of infectious diseases.
Okay, so general surveillance of disease, what does it mean concretely? Which diseases and how does it work? How does it start first?
Right, maybe general surveillance is more like an ECDC wording. It means that I support all disease experts in their surveillance activities from data collection to preparation of surveillance outputs in a generic fashion, so mostly for routine surveillance outputs. Then, you have disease-specific outputs.
We are going to be concrete here because I want to understand how it works, the whole process. So who reports data first?
ECDC is at the end of the chain, so to speak. So the data come from the member states, in which we have colleagues, epidemiologists, microbiologists, for each disease or group of diseases, and they do collect the data at national level. Of course, these data come from clinical settings, so laboratories, hospitals, general practices. So all those health professionals collect this information. Information can be just the number of cases or with more information, demographics, place of infection, outcome, and so on and so forth. So these data are collected at the national level by usually the national public health authorities, could be the Ministry of Health, could be an agency, and those organizations then share these data, or at least a subset of them, with the European CDC on a defined frequency, defined format, and so on. So ECDC, again, is at the end of the chain. We will pool this data and try to make a meaningful analysis out of those.
So they enter into a database. What is the treatment you apply on this data? Do you check that they are quality data? Do you check that they are comparable? How do you do that?
So to capture all this data, we have a centralized platform, which is called TESSI, the European Surveillance System, which is being replaced by a new one that is now called EpiPulse. But the principles are the same. Member states will upload the data set according to a format that is predefined and discussed with them. There will be, it's not just a press the button operation, there will be back and forth because, as you said, we need to make sure the data are as good as possible. So we have automated checks. So you can have scripts looking if you don't have some inaccurate data. For instance, you don't want to have a pregnant male age 100 years, for instance. So you can have these kind of validity checks. Some of the data quality check cannot be automated. For instance, if you have, by some mistake for a fairly rare disease, you double the number of cases, you may miss that. Of course, you can flag if you have more than you would expect, but you need some confirmation. So in that case, we would go back to the reporting country asking for confirmation. Then when we have this, we're all happy with the quality we have, we will produce some outputs for approval. So displaying maybe the distribution of those cases over time, maybe break down by different categories and ask the member states to approve these very basic outputs that we will eventually publish.
You mentioned just before that you could have data like gender or age in the data set. Does it mean that these data are not anonymous?
No, these data are anonymous. There is no way for us to go back and identify those cases. And on top of that, if for some sensitive information, the geographical resolution would allow anyone to identify those cases, we would not report at that level.
Okay. That's something that is important for citizens, I think, to know. What do you do once these data are in your system? You have checked them. You know that they are in a good quality and that they are comparable. What do you do with this data? Where do they go? How do you use them?
So let me just go back a minute on the type of data we collect. It's not that we are collecting data for the sake of collecting them, so it's all objective driven. For a given disease, you have objectives for your surveillance systems, and we try to just collect the amount of data that are necessary to fulfill those objectives. So I think that's very important. And to come back to your question, in that perspective, we will try to produce meaningful analysis and eventually outputs that will help us meet those objectives. So for example, if you're talking surveillance of measles, we produce monthly bulletins to try to capture the epidemiological situation with the target of measles eradication. So it also have an impact on the type of data you collect. You may want to collect information on age, sex, of course, but also vaccination status, for instance, or place of infection.
Where do these data go after being checked?
Right. So they end up in our database. And then as I mentioned earlier, we will prepare some routine outputs. So those are generic for all diseases with very basic indicators. And we try to publish those as quickly as possible to make the data available for any user. I would mention the surveillance atlas of infectious disease with all the diseases under surveillance with some basic indicators in an aggregate format that can be downloaded or explored by anyone. It's public on our website. We then publish some more elaborate outputs, the annual epidemiological report, where on top of some predefined illustration, you will have some interpretation of these data. And then we can also, this is more disease specific. We produce dashboards, for instance. You may have seen some of those for the COVID-19 data, where we follow both the epidemiology but also the rollout of the vaccine. And then maybe some other outputs more advanced that require more advanced statistical analysis will end up in other formats such as peer-reviewed publications, so scientifically reviewed with more advanced analysis. But it takes longer. It's more ad hoc when we want to address a very specific question, as opposed to those routine outputs, which are more generic.
So all these data are available on the ECDC website, I guess, available to citizens freely. In which format they are proposed?
So as I said, there is these outputs where you can actually see the interpretation of those data. You also can download in an aggregate format. Probably the easiest way would be through the Atlas for Infectious Disease. You can also request this data. So if you want to run your own analysis, you're working in a university, you are a student, you are or an interested member of the public, there is a possibility to access a more specific data set. And there is a page on our website that explains how to do this.
Did you receive any complaint from member states regarding the treatment of data or a specific issue?
So I would not say we receive complaints. We receive comments both from our network. So I mentioned this collaboration with the member states. So it's all based on disease network. They consist of representative from all the member states, and with this network we discuss, agree on the type of data we want to collect, the type of analysis we want to do for a given disease or a group of diseases. Then we also receive feedback from users, could be potentially anyone, either on our outputs, so suggestion for improvement, always welcome. So I would not say that we receive proper complaints. Now, we know, it's never timely enough. I mean, ideally, the moment you upload your data, you would like to be able to have your analysis ready, but it's not possible for all diseases. We've tried. I mean, I think the COVID-19 example showed how quickly we could get these data available online weekly for that example. But yes, I mean, there is always room for improvement. You can make mistakes. There can be some error in the data. Then, of course, feedback is welcome, and we do all we can to address those errors.
So you are in a constant dialogue between the member states and yourself to adapt and to adjust the data and the way we show them. But how do you ensure that, for example, if you show the data on a map, all the countries are reported at the same time? Because it would depend on the time where you look at the map. You wouldn't have the same updated data if a country reports late or later than another one.
So in theory, as part of this reporting protocol, we have set deadlines. So if we take COVID as an example, there is a day every week, which is the deadline for reporting data for the previous week. For most other diseases for which we collect only data on an annual basis, we have a data call that may take a bit longer, but you report data for the previous year. So theoretically, those data in terms of time should be comparable. Now, we know that not so important if you report data on an annual basis, but if you do so on a weekly basis, of course, if you're at your regional level or national level, the data collection is done at different times. So let's say we collect data on a Thursday, but in your country, the collection is done on a Friday. Then you would miss some of the cases for that particular country. This would correct itself because you have also, the database are not something that will not change. So it's possible to correct data reported for previous weeks, for instance. So you could correct that. There is also for some other disease, like HIV maybe is a good example, for which we know there is a delay to report your data. So there are also statistical tools that would help you to correct for those reporting delays. So there are both technical and more ways to address these issues.
So we could say ECDC is the European hub for data on infectious disease. So a lot of organizations are using this data and are using the data set you provide. So do you have links with this organization? Do they contact you because they would like to have further information on one of the data sets?
To answer your first question, yes, I think definitely the ECDC is a hub for infectious disease surveillance data. You may have heard a lot of talk about whether these data, especially for COVID-19, were comparable across countries. I think it's impossible to have fully comparable data because we have different healthcare systems, we have different healthcare seeking behaviors, and so on. Yet, our big added value is that we have a common understanding and agreement on which type of data should be reported and how. We use, I should have mentioned that earlier, an agreed case definition. So we make everything we can to make these data more comparable. Back to your second question about collaboration with other similar agencies, we do. We have joint surveillance activities with the World Health Organization Regional Office for Europe for some diseases such as tuberculosis, HIV, or influenza, and COVID more recently. We have collaboration with all the major other CDCs, American CDC, the Chinese CDC, the newly created Africa CDC. We also have, of course, we have very strong link with the Public Health Agency within the European Union, but also beyond with many other countries. So that's very important, both for surveillance activities, but also for the epidemic intelligence activities. I think you already had a podcast on that topic, and those collaborations are key when we are screening, when you're detecting some outbreaks elsewhere in any country potentially, and you need some kind of confirmation or additional information on what's there.
Yes, on epidemic intelligence, we had a podcast. It's the episode 2 called Looking for Signals with Thomas Mollet, another specialist at ECDC of epidemic intelligence. Now I have the impression I know everything on data from the moment they entered into the system and the time where they are published on the ECDC website. Thank you very much, Julien, for your time and this interesting conversation.
Thank you, Catherine. It was my pleasure.
We hope you enjoy listening this podcast about general surveillance of infectious disease. If you would like to know more, please visit our website ecdc.europa.eu or follow us for the latest news on social media.